This presentation is intended for general educational purposes only. It is not medical advice. It is intended to present you with our own opinions regarding the topics presented. It is not the intent for the presentation to be a substitute for seeking personal medical evaluation. It is commonly said that a person who treats themselves has a fool for a patient. All symptoms have a list of potential causes. Only a trained medical professional can optimally apply available tools to return you to your best possible health. It is our hope that this presentation makes you a more well-informed and better consumer of healthcare services.
Hi, my name is Dr. Shawn Panzer, and I'm a gastroenterologist in Denton, Texas. I'm with North Texas Gastrointestinal Associates. My phone number is 940-566-4720. Our website is www.ntgia.com. And today we're going to talk about a not so glamorous or academic topic, which is gas. And I can assure you that when I went through my training at Johns Hopkins many years ago, that this was not a lecture that we had. It's not a topic that gets a lot of attention from a research standpoint, from a funding standpoint in regards to that research, or in our literature as a topic of treatment. But it is a really common symptom, really frustrating symptom for people, and it is something that I think is worth knowing about, and that's what we're going to talk about today. When you look at the definition of gas or bloating, there's just not a uniform definition. It's more of a sense of fullness. It's a sense of distension. Sometimes people will come in and they'll have physical distension. Others will feel like they're distended. Then you have gas symptoms like excessive belching. You might have symptoms of passing gas successfully. That gas may smell much worse than it used to. And so there's a great variety of symptoms that go with this, but there's not a specific definition. When you look at the literature on this, the studies have shown that people who feel gassy have the same amount of intestinal air by X-ray as people who don't feel gassy. And so it obviously is something that is related more to the way the wiring of the stomach, your nervous system in the abdomen, is set up, and people may indeed have the same amount of gas but have different symptoms related to that. But there's no doubt that there's some real underlying pathology that needs to be considered, and many times I've found that this is reversible. Now, in regards to the symptoms you might have, I've already alluded to some of those. Obviously, just starting from the upper, just starting from the top and going down, a person who complains of gas may be having problems with burping excessively. And so in that situation, you may be dealing with a problem with the valve at the lower esophagus, which is called the lower esophageal sphincter. We know that, and you can see this in my reflux video, but we know that 75% of reflux events or belching related to relaxation of a valve in the upper esophagus. In the lower esophagus, excuse me. In the stomach, you may have a situation where the stomach may not empty well. So you may wake up in the morning and feel just perfectly fine, and then as you go through the day with your eating and everything, stomach gets bloated, gets distended, and you may have issues even with nausea and vomiting related to that. Then as you get into the small bowel is obviously extremely important in terms of processing everything we put into our mouths. And so if there's a problem with the lining of the intestinal tract, or if you have problems with the way that your nutrients are being processed, then you could end up with those substances getting too far down to the intestinal tract and not being absorbed properly. And then of course you have the colon, where you have billions of bacteria. You have probably 50 main species, but over almost 1,000 species have been identified. Some have not even been fully classified, but they work in concert with your colon and definitely generate gas and can be a source of problems there. So there are a lot of things to consider, and it's not a symptom that I think you have to suffer with necessarily, and I think there are a number of reversible causes that have to be considered. In terms of kind of framing our discussion, I want to go over the normal anatomy. So in framing our discussion, we want to go over the normal anatomy, which I do this in all the videos, again, because of this. I think it just helps you understand what we're thinking as physicians. So when you swallow, food goes over the tongue, and it comes down this long tube called the esophagus. Your lungs are on either side, your heart's here, your windpipe's here. Food goes into the stomach where it mixes with acid. Muscles of the stomach grind up the food. It sits there a while, and then it goes into this C-shaped area called the duodenum. That area is important because two things empty there. One is your pancreas, which runs right here behind your stomach. It makes the juice that you need to break down food. It also makes insulin, which is important for your blood sugar control. The other thing emptying there is your liver, and it makes a lot of things, one of those being bile. Bile goes into tubes called bile ducts. They come into one main one that goes through the pancreas and out into the intestine. Your gallbladder is attached here and serves to store the bile until you eat, and then squeezes the bile in to mix with the food. From there, it goes down about 23 feet of small bowel, during which time nutrients are brought into the body, water and waste is left behind. That comes out in the right lower part of the belly in an area called the cecum. Your appendix is there. As your water and waste goes up your right colon, across the middle, down the left colon, and then makes this S-shaped turn to where it comes out, the water is removed and the stool becomes firm. So when you look at the tools that are brought to bear in terms of diagnosing the underlying cause of excessive gas, there are the usual tools are employed in my specialty. So you have your blood testing, and blood testing in regards to gas is usually not that helpful. The one thing that can be helpful is what's called a folate level. As you may know, folate or folic acid is a vitamin, a very important vitamin in our diets. And so in a situation where you have too many bacteria in the small bowel, which we'll go over that specifically in a minute, the bacteria make folic acid, they make folate, and so the folate may be high. Similarly, bacteria break down vitamin B12, so your B12 level may be low. Usually, you're not going to see things like anemia, disturbances in the body salts, things like that. So not so helpful. One thing that can be helpful is if you have a problem with your pancreas. Basic blood work, including amylase, lipase, and a fecal test known as stool elastase. These things can be employed or checked, I should say, to determine if your pancreas is working properly. But basic blood work is usually going to be fairly normal in people who have gas. The second tool that can be used, of course, include radiological studies. And again, basic X-ray to make sure that there's no blockage, especially if a person is coming in with sudden onset distension, particularly if they have nausea and vomiting. So that can be helpful. CAT scan can be helpful as well because it can show if you have evidence of bowel wall thickening, like you might see in something like Crohn's disease or ulcerative colitis. And barium studies can definitely be helpful in certain settings because they can show us structural problems, particularly in the small bowel, where you might have little pockets known as diverticula, which again is like diverticulosis you hear about in the colon. So that's something that can be used. And of course endoscopy. And endoscopy can be is very helpful in terms of looking at the lining, particularly in the small bowel, and of course the colon. If you have any issues with underlying irritation, you need biopsies to show that, and endoscopy is obviously an important tool. Many times you do all these different use these different tools, and you may not come up with anything at all. A test that I started doing here recently is hydrogen breath testing. This has been around for a while, and what it looks for is there are three tests. One looks for lactose intolerance, where you can't break down milk sugar. The second one looks at fructose intolerance, which is fructose is fruit sugar, and it's used in high fructose corn syrup, which sweetens almost anything sweetens almost any processed food that is sweet. And then the third one looks for small intestinal bacterial overgrowth, which we'll go through here in just a minute. And these are real simple tests. In the past, they were not that accurate. I think the technology has finally gotten to a point where it's clinically useful, and so that's another tool that we bring to bear. Again, we can do stool studies, for culture, for parasites, looking at whether or not there's evidence that maybe something's not being broken down properly, or that something is being passed through that should not be making it down into the stool. And so these are the different tests that you'll generally use, and there's some other ones that are more specific, but these are the basic ones. Okay, well, I'm going to go out of the picture for a little while here as we go through this anatomy, and this chart here just shows you different diseases that affect the intestinal tract, and you may not be able to see it extremely well. I know this is kind of low tech, but I wanted to just use this to frame our discussion about specific things you want to think about when you feel gassy and bloated. So starting up here in the esophagus, as I said a minute ago, passage of belching, which is known as eructation, is usually a function of this, I call it a valve, but it's really not a valve. It's kind of a high pressure area of circular muscle, which keeps the esophagus closed. And so when you swallow, food goes over the tongue, and then, like I said, it comes down the esophagus. And then as the food approaches the lower part of the esophagus, this opens up, this valve, the lower esophageal sphincter opens up, and then the food drops in, and then the valve closes back up. And so, as I said a minute ago, about 70-75% of reflux events where acid and digestive juice is coming up into your esophagus, those occur because this valve opens up. And so people who belch, they're bringing up air instead of bringing up liquid. And so that's one thing that can happen. And basically, there's another video on reflux, but almost anything that tastes good and is bad for you can cause this valve to open. Distending the stomach is, for example, it tends to lead to what are called transient lower esophageal relaxations. And so that's one thing you think about when people belch. A lot of times you have to just do some dietary modifications. Also, when you swallow, when you use a straw, you tend to take down a lot of air. And air has to either be belched up, or it has to pass all the way through the intestinal tract and come out the other end. Air is mostly nitrogen and is not absorbed by the gastrointestinal tract. And so, again, it's either got to be belched up or that. So if you're an air swallower, which you can actually see in people who have advanced lung disease, for example, or it can just be nervous habit or just a matter of use of straws, chewing gum, you're going to be swallowing a lot of air, and that can obviously make you gassy. Now, as we move to the stomach can be a source of a sense of distension and gassiness and bloating, feeling like you're filling up easier than normal, because the normal stomach function begins in this top part of the stomach. And so when you swallow, food comes into this top part of the stomach, which is called the fundus, and this part of the stomach undergoes what's called receptive relaxation. It just distends out, and it's about 3 times the size when you eat as compared to when you're not eating. And so the food will then pass down to the lower part of the stomach, and that's where the grinding action and digestion occurs. And it has to be ground down to a particle size of about 3 millimeters or less, and it has to be diluted out before it's allowed out of the stomach through this valve called the pylorus and into the next part of the bowel, which is the duodenum. And so if you have a problem with this process, then you can obviously have symptoms. And so, for example, people who have, let's say, an ulcer like you see right up here, as that stomach stretches, that ulcer gets stretched too, and you get a feeling that you can't eat anymore, and so you may have what we call early satiety, meaning that you're filling up easier than normal. But more specifically in regards to gas, if you're thinking about a stomach problem, you're usually thinking about a problem either with this valve down here, the pylorus, not opening when it's supposed to, allowing things out, or the stomach being slow, which is called gastroparesis. And we're going to get into that more in the stomach discussion on another video. But suffice to say that when the stomach is not emptying well, then you end up with the stomach being distended. It can get worse through the day. You get a sense of gassiness, and this is an area that has to be thought about in terms of a cause of symptoms. And we know that the way the stomach is supposed to empty is that about 50% of what you eat should leave the stomach within about 90 minutes, 70% within 2 hours, and over 90% within 4 hours. And so if you don't have those numbers, then you have what's called delayed gastric emptying or gastroparesis, and that is one of the things that we think about. And again, there are specific medical therapies. There's specific medical therapies for that, which we'll go over that in a minute. Then as you move down to the small bowel here, as I said a minute ago, this is where your bile comes in, and it's also where the pancreatic juice meets up with the food. So all that gets together with the food, and that's really where digestion gets going in earnest. So if you are a person who has, let's say, you've been an alcoholic over the years, or if you can even have problems with your pancreas due to medications, family history of pancreatitis, the pancreas can get burned out. And when about 95% of the pancreas has been destroyed, you start having problems with what we call maldigestion. That's also about the same time that you'll get diabetes, because the pancreas makes insulin, and as the gland is destroyed, you lose that capacity as well. And so when you don't have the digestive juice coming in, then you have problems with fully digesting your food. And so that can get far into the intestinal tract, and as you get farther down into this area near the end of the small bowel, bacteria you start seeing more and more bacteria there, and of course you have billions of bacteria in your colon, and so these bacteria will break down the food, and you end up with basically maldigestion. But in that process you get the formation of gas, and so if you malabsorb as little as 5 grams of carbohydrate, so if you look on your candies or whatever, you're getting much more in terms of carbohydrate than that. But just 5 grams of carbohydrate can be turned into about a liter of gas. Well, a liter is about 1 1/3 quarts, and that's a lot of gas. So that's something that you have to think about. So again, in talking to people, get a history suggesting a problem with the pancreas. Then there are some fecal tests that we can do to make that diagnosis. Similarly, if there's a problem with the bile interacting with your food, you can have problems with fat digestion primarily. Also, the bile is really important for activating the juice coming out of your pancreas, and so again, you can have a similar process, and so that's a consideration as well. But again, that's usually that's really not that common of a problem in my practice, at least. Then you get into the small bowel. The small bowel is extremely important in processing our nutrients. Almost nothing is left behind. You basically just have water and waste left behind when the small bowel is working normally. And so there are a lot of things that can happen here. The importance of this whole system, one of the things that's really important to this whole system is its ability to clean itself out, that things need to keep moving on through. Anytime things don't move through, then you have you have stasis, and then you can have bacteria build up, and the bowel does not work well. So one of the things you have to think about when a person is having gas and bloating is the possibility that there's a mechanical blockage. An example of that is this inguinal hernia right here. And you can see that this is your inguinal canal coming through here, which separates your leg from the lower abdomen. And you can see that the bowel has gone into this space down here and created this, what we call a closed loop. And so when that occurs, the contents that are in the bowel above it, the bowel's trying to push that through. And so a lot of times people will get abdominal pain, and that'll be followed by with diarrhea and distension, and sometimes and many times the person will start throwing up, and that material that they throw up will be bilious because the bile has come into the fluid, and now you're throwing it back up, so it has a chance to, that's what you end up seeing. And so so you have to always consider a mechanical problem like this. And obviously, if you think that's going on, that's where you're going to be focusing more on your x-ray type studies, that kind of thing. So mechanical problem is important. You've heard of diverticulosis, which is right here. These are little sacs that form, in the case of right here, off the colon. The same kind of thing can happen in the small bowel. And so when diverticulosis is present in the small bowel, you can have stasis. Again, the bacteria can accumulate there and grow. And so, again, that can lead to symptoms. The main thing that we think about in regards to the small bowel has to do with the way the lining is working. And so the lining of your small bowel has all kinds of these substances that are called enzymes, and they break down various things. They break down your protein, your carbohydrates, your fat, and absorb those nutrients into your into the bloodstream, which then goes up, or blood vessels that then go through the liver, or into lymphatics in terms of fat that will ultimately go into the same kind of circulation. So problems with the lining are really important considerations when a person is gassy. For example, a person can get what's called celiac sprue. You've probably heard of a gluten-free diet. Well, that is linked to celiac disease. Celiac disease is an allergy to wheat, and it's not like a rash, or you don't get a rash, that kind of thing for the most part. But what happens is the lining suffers damage from the immune system being overactive, and so then you lose the ability to process a lot of your nutrients. So in the old days, we would see this in older Caucasian men who would come in with wasting and diarrhea and weight loss. Nowadays, gas can be one of the earliest symptoms of that, so it's a strong consideration. If there's the second thing that can cause this again is inflammation of the intestinal tract. A good example of that is Crohn's disease, which can affect pretty much anything you see here, any of the intestinal tract you see here, but what it does, again, is it causes inflammation, you get lining damage, and then you get subsequent nutrient malabsorption. Usually you're going to have other symptoms other than gas, but early on it can present that way. Another thing you have to think about is, so inflammatory conditions have to be considered. If you don't have an inflammatory condition, you're passing a lot of gas, most of the time you're going to be dealing with carbohydrate malabsorption. So you're not processing sugar that's coming through your diet in various ways. We mentioned earlier lactose intolerance, which occurs, which is actually pretty common, especially as you get older, certain ethnic groups. And so you drink milk, the milk sugar goes on through, it's not processed properly. Bacteria start to process it here low in the small bowel and in the colon, and that generates a variety of gases, methane, hydrogen, a number of things, and those will then have to be passed out of the intestinal tract. Fructose intolerance. Fructose, like I said earlier, is used in almost any kind of anything that's sweetened artificially, and processed foods, that kind of thing. So we get a lot of fructose. Fructose is not easily processed by the gut, and so some people just don't tolerate it well. And so again, the sugar comes on through, same thing happens. Another condition is small intestinal bacterial overgrowth. Normally you have, like I said earlier, 50 dominant species approximately in the colon, but you can have many more than that. Billions of bacteria. It's been said that, I still have a hard time believing this, but it's been said that 50% of your stool weight is bacteria and their products. So but you have particular types in the colon as compared to the small bowel. The small bowel has very few bacteria, and they're a particular type. They're generally oxygen loving, whereas the ones in the colon do not like oxygen. So if the bacteria that are present in the large bowel get into the small bowel, they interfere with the bile, they break down the bile, and they also interfere with these digestive enzymes we talked about. And so again, things aren't processed properly. And so there are a number of, I could probably go over a bunch of other ones, but I think those are the main ones. Another thing you have to consider, which I think presents more with diarrhea than gas so much, is what we call bile acid malabsorption. So bile comes out of the gallbladder, or if you don't have a gallbladder, it goes right into the bile ducts out of the liver, and then it comes into the intestinal tract. From there, it goes down the small bowel, and then it's reabsorbed in this last section here of the small bowel, which is called the terminal ileum, and then recirculated back to the liver. And so you have what we call enterohepatic circulation of the bile, and that occurs several times during just a typical meal. So this is a process that's ongoing all the time, particularly when you eat. As we get older, sometimes we don't reabsorb that bile properly, and too much of it gets into the colon. That will give you what's called a secretory diarrhea, and that can lead, like I said, a lot of times to diarrhea, but you also have to think about it in people who are gassy. We also know that when the gallbladder is removed, probably 5% of people develop diarrhea, and it's related to the way the bile is processed. And then finally we get down to the large bowel. The colon obviously is involved in reclaiming the water, dehydrating your stool down to what you pass every day. And so approximately a liter of fluid, or again about a quart and a third of fluid, comes into this right side. And then as it makes the journey across the colon, 90% of that water is reclaimed. And so what you pass over here is about a tenth of what you had come in over here on the right side. The colon is quite muscular over here on this left side, and then it gets more thin-walled as you come this way. So if you have problems with your bowels, if you're constipated, then you get back pressure over here, and that tends to stretch the colon out more as you get over on the side. So obviously constipation is something that you want to deal with in a person who has gas. But again, if you eat a lot of fiber, for example, fiber is most cellulose, and well, there could be two different types of fiber, but cellulose is an important component of that, and we don't have the machinery to break that down. And so that gets into the colon and is going to be broken down. And that's a good thing, actually, because it provides fuel for the colon lining. But it will make you gassy. So if you have a higher fiber diet, you're going to probably pass more gas, and that's not abnormal. So if you've been around farm animals, you know that they obviously pass a lot of gas, and it's been said that a dairy cow passes more greenhouse gas than a Hummer produces in a year. So that's a normal function. And so that's kind of an overview of the different things that can make you gas. Okay, so what we're going to do now is we're going to go through and talk about my approach to gas and the kind of questions that I ask, which I pretty much have covered that in going over the different possibilities, and then we'll go over the treatment, and then just kind of the consequences of letting such a thing persist. So when it comes to the management of people who feel gassy, obviously the most important part, in my opinion, is the history and physical. And unfortunately, I think a lot of people are getting away from the basic history and physical, but I think this kind of diagnosis requires a good history. You need to find out what precipitates what precipitates the sense of gassiness, what makes it better. Does the bowel movement make it better? Does eating, not eating, does certain food diet elimination, does that have an impact on it? You need to know what makes it better, what makes it worse. And then what's really important is deciding if, just like in all things that have to do with gastrointestinal disease, you need to decide if there are some warning symptoms, things that make you think of a more serious problem, like malignancy, like pancreatic, a problem with the way the pancreas is working. Obviously colon cancer, which is really common. And so that's where the history and physical directs you, because you can spend a lot of money and on this, and with the high deductibles that we're seeing now, and the kind of unfortunate situation we have in our healthcare system, you really want to be efficient in terms of using a person's resources, and insurances. People think about insurance as being this thing that's out there, but insurance money is our money. It's money that we put into it, and then it's distributed by the insurance company. So I think the history and physical is important. Finding out about family history of course, looking at a person's surgical history. Very important, because if a person has had abdominal surgery, they could have abdominal adhesions. That could be leading to intermittent bowel blockage. You need to know about the other medical problems that exist, from diabetes, for example, which can slow down the stomach. It causes constipation. That's the most common manifestation of diabetes in the intestinal tract. And so you need to know that. You need to look at the medications. Medications have all kinds of effects. Did a person get antibiotics recently? Did they get put on a new medication before this started? Is a medicine slowing down the gut? Is a medicine causing constipation? And so that's important as well. And then as you go through the family history, is there a family history of celiac sprue? Is there a family history of lactose intolerance? And so again, another important thing. Social history. You want to know what kind of dietary plan does a person follow? Do they drink a lot of milk? Do they take in a lot of fructose? Do they eat certain kinds of fruit that can be rich in what are called sugar alcohols that cannot be absorbed? Does a person have a significant drinking history, and could that have had an impact on the way their pancreas works? And then you also want to know just your general review systems. Is a person running fever? Did they travel out of the country before this happened? Is a person do they use well water that could be infected? And a lot of times other conditions that affect other parts of the body. Some of the inflammatory conditions that you see involving the joints. All these things need to be explored because they can have an impact on the intestinal tract. So the approach, that's the first thing. And so usually I'll get a pretty good idea of what's going on. If a person has not had a colonoscopy, we're going to do that. If a person is having symptoms like they feel that they're filling up easier than normal, or they're losing weight, or they have a low blood count, then we're going to probably do an upper endoscopy as well, so I can look at the way the stomach is. I can look at the structural aspects of the stomach, and again, CAT scan might be used depending on the symptoms I'm hearing. Is a person having obstructive type symptoms, and that will obviously be a part of it as well. But most of the time, all that stuff is going to be negative. If a person's having diarrhea, stool studies will be important because we want to know. The stool studies are to the gut what a urinalysis is to the urinary tract, or an X-ray is to the lungs. It gives us a window into how well the gut is functioning, and so we can culture, we can look to see if a person is wasting salt, if there's evidence of them wasting carbohydrates into the stool, and so stool studies can be a really important part of it. One of the things I think that's become important is using the hydrogen breath testing, and so that's something that also can be important and helping us diagnose the lactose intolerance, fructose intolerance, and the bacterial overgrowth. And so that's kind of the approach. It just depends on what I hear. And then another thing is what's called a gastric emptying study, where we look to see how well the stomach is emptying, and that's what we use for gastroparesis. So when it comes to the treatment, obviously it's going to follow the diagnosis that we make. And if you're dealing with, you start just like we did, start with the stomach. If you look at if a person looks like they have a problem with stomach emptying, then we have medications that we will use to help the stomach empty better. And obviously we modify the diet so that instead of having 3 main meals, you'll have 6 small meals, usually around 300 to 400 calories per meal, with a low-fat diet. The stomach processes liquids very quickly, and the more complicated the food and the more work that's required to get it into proper condition, then the slower the stomach is going to empty. If a person has a pancreatic problem with the way the pancreas is working, then we have pancreatic enzyme therapy. It's not the kind of these enzymes you see over the counter, but they're actually a replacement for the pancreatic juice. With the biliary tract, like I said, that's usually not a big issue. But if we think a person is malabsorbing bile, then we can use a medication that will kind of just bind that up essentially, and help us and help to firm the stool. When you get to small bowel disease, you obviously have celiac sprue. That's something that we would want to exclude, as we mentioned. In that case, you have to go on what you know as a gluten-free diet. If a person has lactose intolerance, you can use Lactaid, or obviously avoid milk products. Many times people think they have lactose intolerance and they do not have it, and they've been avoiding dietary lactose unnecessarily. And so I think that's something that's important to confirm formally. If you have fructose intolerance, then same thing. You got to avoid fruit. You got to stay away from sugary drinks and most things that are sweetened artificially. With the small intestinal bacterial overgrowth, that is, I think, the most important thing that we see. This can occur because the bacteria can get into the intestinal tract, into the upper intestinal tract, because so many people are on antacids, for example. And when you eliminate the acid barrier in the stomach, then you end up with bacteria being able to get into a very nutrient-rich environment in the small bowel. So that's something that I look for real commonly in people who have gas. And studies have shown that antibiotic treatment of people who have gas or what we call diarrhea predominant irritable bowel syndrome, about 60% will have improvement of symptoms. So that's a really important thing to know. If a person has a problem with bacterial overgrowth, I usually will do a small bowel follow-through, which is just swallowing barium, mainly just to make sure there's not a structural problem that might need to be corrected surgically. If I think they're having intermittent bowel blockage, then usually we'll send the patient to a surgeon for at least laparoscopy to look in the abdomen. X-ray studies do not show you adhesions; they only show you evidence of blockage. Then moving into and then if none of that stuff works, then I will go to kind of some over-the-counter therapies. Activated charcoal, for example, which has been shown in small studies to be helpful in gas, patients who have gas, and I like it. And then also peppermint oil. We'll sometimes use that. Gas X, which is also known as Mollicon or simethicone, I just haven't found it to be that helpful. It's really good for breaking up gas bubbles in endoscopy, but it just doesn't do much for patients. But sometimes it's worth trying. Probiotics, some people swear by those. The data continue to remain really weak, and you almost just have to try yourself. I personally don't take them. I think that eating yogurt daily is good. It's a natural way. The bacteria are alive. Probiotics that are over-the-counter and at room temperature, most of those bacteria are dead and are nowhere near the quantities it's thought that you may need to get an effect. And then when you get to the colon, it's really important to have regular bowel movements. A normal bowel movement frequency is anywhere from 3 times a day to 3 times a week. People who feel gassy, I try to get them more towards 1 day of a bowel movement a day, so that everything is moving through. The colon's not being distended. One thing that you can see is that in this kind of left upper part of the belly, and I didn't show this earlier, but in the left upper part of the belly you have a turn of your colon, and in the right upper part of the belly the same thing. And some people will get what we call hepatic flexure syndrome and splenic flexure syndrome, which is where we think you trap gas in those areas. And so sometimes antispasm medications will be used. And then again, in some people, spasm type medications, or maybe even low-dose antidepressants to kind of raise their pain threshold will be employed. So that's kind of a summary of what I like to do. Obviously, you have to tailor things according to the individual, and that's what I certainly try to do. So anyway, I hope that was helpful. One other thing I should say is that if we just can't figure it out at all, then we'll sometimes use what's called a FODMAP diet, FODMAP, which is like it's a really significant elimination diet. And what you hope to do is to get the symptoms under control and then slowly add back individual items to try to hone in on what exactly is causing a problem. But it can be difficult because food allergy testing just doesn't really help. I don't send people for that, and I just don't think that the FODMAP diet is good, but it's a tough diet to use. So I hope that this was very helpful. My goal is for you to get to be educated about this and other topics, and hopefully be a wiser consumer of healthcare. Whether you come to see me or you go to see another gastroenterologist, it's good to have some knowledge before you walk in the office. You can better relate your symptoms, and then you can also, I think, be a better consumer in terms of deciding what testing you can afford and what may be more relevant to your symptoms, because you live with your symptoms every day. The doctor sees you for 30 minutes or so and has to make the assessments. So anyway, thank you so much for purchasing this video, and I hope you take a look at the rest of the videos we have, and thanks again for your business. Hi, I'm Shawn Panzer, and I'd just like to take a few minutes just to let you know about some of the different things that we offer through my office. Obviously, I'm a traditionally trained gastroenterologist from Baylor College of Medicine in Houston and Johns Hopkins up in Baltimore. But obviously, things change over time, and so I think it's important that a person also get kind of keep up with the times and be contemporary. And you also want to balance that with things that have worked from the past, because a lot of times things come up that that seem to be awesome and something you want to put in your practice right away. But a lot of times you need the kind of the percolation of time to make sure that the procedure is truly safe and is one that's going to benefit a patient. And that does take a combination of experience and knowledge of the literature and other things. So I just want to make you aware of some other things that we do. Of course, you can obviously see me in the office, kind of the traditional way, but I also have telemedicine, which allows a person to have an office visit, a follow-up office visit over Google Duo or the iPhone FaceTime. And I can't do new patient visits that way, but it is covered by insurance and Medicare. And I use that a lot in people who have to drive or can't get here easily or off in other places like in school, that kind of thing. We also have a nurse practitioner named Tony Perkins. She's sees patients while I'm here in the office. And her practice is mostly focused on helping people who need to be worked in that cannot be worked into my schedule. And so she's also available. We also do in-office hemorrhoid banding with a system called the CRH O'Regan system. And this is kind of the latest version of hemorrhoid banding. I've done hemorrhoid banding since I read about it, the endoscopic version in 1996. But this newest version is basically a painless version that does not require colon preparation. I can do it right here in my office, again covered by by Medicare and also by private insurance. We also have a type of radiology device that's called FibroScan. This allows us to quantitate, not only it uses an ultrasound technology which allows us to quantitate how much fat is in the liver, and it also allows us to tell liver stiffness, which correlates to how much scar tissue is in the liver. So if you have a chronic liver problem, such as hepatitis C or fatty liver, then we can use this to, in a non-invasive way, to give us an idea of how much scar tissue you have. This may lead to a change in your management, either through medical management or to referral to a tertiary level medical center / liver institute for more for access to possibly clinical trials and other things. But in the past, the only way we could do that was with liver biopsy. You can also get similar information from an MRI, but MRIs are very expensive and it's very difficult to do a good MRI. The last thing I want to talk about is an alternative medication line that we're developing for digestive diseases. And the alternative medications are it's a big industry. There are a lot of people that carry the medications, drugstores, grocery stores, and all that. And there are just so many different products and so many different things out there, and it's just kind of mind-boggling, really. The unfortunate thing with a lot of those, for the vast majority of these supplements and minerals and herbs and these things, is that there's just no clinical data. So a doctor like me who prescribes your standard prescription medications, all of those had to go through scientific studies in which they were compared to placebo. They went through animal trials. They went through patient trials. And then a lot of times we have years of experience with these. And so we know that they work better than a placebo. But a lot of people are turned off by big pharma and the expense and just the suspicion that the medicines are not good for them, side effects, this kind of thing. When you turn to alternative medications, you have even a worse problem because you have so many different chemicals that are put into one product. You don't know which one works. You don't know which one may be interacting with medicines you're already on, that kind of thing. But people seek that care a lot and go to non-traditionally trained individuals and put a lot of trust into people that have not spent a lot of time either practicing medicine or studying medicine. And so what I'm trying to do over the last year is educate myself more about the things that are out there, try to get as much information as I can, scientific information, to help me make decisions as to what may work and what may not, and what does not work. And so that's what I've been trying to do is we're putting together a product line that will that will allow us to treat the things that we see. And so we're going to use these as a combination with the traditional medications, and hopefully we'll get better results as a result of that. These medicines will be available in the office. They're also going to be available online on eBay store as well. And so please give them a look. And obviously when you come to the office, I'll definitely describe those. But again, the idea is to get some kind of a product line that I can feel good about in terms of the production and also standardization, and where we can combine it in a controlled way, as compared to just going out and taking a handful of different supplements that may be countering each other, or just not doing anything for you and wasting your money. The last thing I'd like to talk to you about is hydrogen breath testing. This is technology which allows us to measure how much hydrogen you're exhaling, and our bodies don't make hydrogen, only bacteria do. And so what this allows us to do is to look at, to see whether or not you are possibly malabsorbing different things, such as lactose and lactose intolerance, fructose intolerance, and also what's called SIBO, which is known as small intestinal bacterial overgrowth. This is a condition in which you have bacteria in your small bowel which should not be there, and in too high quantities, and as a result they are interfering with the function of the bile and also the digestive juice made by the pancreas and by your small bowel lining. When that happens, then you don't absorb things the way digest and absorb things the way you're supposed to. They go lower in the bowel where they're broken down by bacteria, and that's fermentation, and that can lead to anything from gas and bloating all the way to diarrhea and even weight loss. So something that's part of our workup of symptoms like gas, diarrhea, and bloating. So we're, like I said, we have these available now. We're always looking to add things I think are going to be helpful. These things are covered by insurance, and with the exception of the supplements. And I hope you give these things a look. Thanks for your time.